Hello friends, this is third video on CNS regarding all important points for NEET PG. Kindly watch the full video. First of all, LMN and UMN type of lesions. The difference between them are given in this table. The main point is Babinski sign. It is positive in UMN type of lesion and negative or downgoing in LMN type of lesion. The concept is the lesion above anterior horn cells is considered as UMN type of lesions and the lesions below anterior horn cells are considered as LMN type of lesion. But the question is, when the lesion is at anterior horn cells, it is considered as LMN type of lesion. The next and important topic is Brown-Séquard syndrome. It is also called as hemisection of spinal cord. The lesions include, first of all, due to involvement of dorsal column tract, there is ipsilateral loss of fine touch, vibration, proprioception and two-point discrimination. As information from dorsal column tract ascends ipsilaterally in the spinal cord and the fiber crosses in medulla. So, in the lesion, the loss will be ipsilateral, whether it is above or below the lesion. Then next is spinothalamic tract. Information ascends contralaterally in the spinal cord, that is, fibers crosses in the spinal cord itself. So, at the level of lesion, there will be ipsilateral loss of pain, temperature and crude touch. And below the level of lesion, there will be contralateral loss of pain, temperature and crude touch. The next is motor loss. It is due to involvement of corticospinal tract. There will be ipsilateral motor loss as descending fibers are already crossed in medulla. Then main thing to know is whether the lesion is UMN type or LMN type. At the level of lesion, the lesions will be LMN type. So there will be hypotonia, flaccid paralysis and areflexia. And below the level, it will be UMN type of lesion. That is loss of power with hypertonia, spastic paralysis, hyperreflexia and positive Babinski sign. Next is Syringomyelia. It causes dissociated anesthesia. It is due to lesion of decussating fibers of lateral spinothalamic tract. And most common site of syrinx is lower cervical region. So it causes cape-like distribution of sensory loss, that is wasting of small muscles of hand. Because of loss of sensation, if the patient having burns or any injury, the patient won't be feel any pain. And Syringomyelia is associated with cherry malformation type 1. And next topic is bladder. I have made separate video in bladder and neurogenic bladder. I will give link in the description below. Next is few important cranial nerve reflexes. First of all, corneal reflex. Efferent is ophthalmic division of 5th cranial nerve and efferent is 12th cranial nerve. Then jaw jerk. Efferent and efferent is both by mandibular part of 5th cranial nerve. Then pupillary reflex. Efferent is by 2nd cranial nerve and efferent is by 3rd cranial nerve. And last is gag reflex. Efferent is by 9th cranial nerve and efferent is by 9th and 10th cranial nerve. Then motor neuron disease. Most common type of motor neuron disease is amyotrophic lateral sclerosis. The pathology is at anterior horn cells and the pathognomic feature is fasciculation. In motor neuron diseases, eye movement, sensory system, bowel and bladder and sexual function is normal. And the most confirming investigation is EMG, that is electromyography. And the CSF findings is normal. And the important drugs used in treatment is riluzole, which is glutamate antagonist. Then edaveron, it causes breakdown of O2. Then baclofen or tinazidine is used for spasticity. These were the few important points for motor neuron diseases. Next is Friedreich's ataxia. It is most common inherited ataxia. It involves posterior column and pyramidal tract. So there will be absence of deep tendon reflexes with positive Babinski sign. The question may ask as an absent ankle jerk with extensor plantar. The answer will be Friedreich's ataxia. It is one of the nucleotide repeats disorder and the nucleotide repeats are GAA. It is autosomal recessive type of disorder. The simple mnemonic is FAGAAAR, FAGAR, that is Friedreich ataxia, GAA repeats and autosomal recessive disorder. The next is subacute combined degeneration, SACD. It involves posterior column, pyramidal tract and peripheral nerves. The most important point is the exaggerated deep tendon reflexes with positive Babinski sign and it is associated with vitamin B12 deficiency. This point may be given in the history. Then Myasthenia gravis. I will cover most important points only. The grading used for Myasthenia gravis is Osserman grading. Then one of the causes is thymoma, which is not associated with hypogammaglobulinemia. Then best screening test is edrophonium test or tansilon test. Then most specific test is acetylcholine receptor antibodies. And most sensitive test or confirmatory test is single fiber electromyogram. Then iSpec test is used for myasthenia gravis, and the nerve stimulation test will show decremental response, and the drug of choice is pyridostigmine. Then drugs which are contraindicated in myasthenia gravis are amyloglycosides, quinolones, beta blockers, class 1A antiarrhythmias, quinine, and non-depolarizing muscle relaxant. Then Lambert-Eaton myasthenic syndrome. It is associated with small cell carcinoma of lung. It is one of the paraneoplastic syndrome. There is mainly presynaptic defect of calcium channels, and in myasthenia gravis there was postsynaptic defect. Here deep tendon reflexes are decreased, but in myasthenia gravis it will be normal, and there will be no bladder involvement in myasthenia gravis, but in Lambert-Eaton myasthenic syndrome there will be bladder involvement, and the nerve stimulation test will show incremental response, and the drug of choice for Lambert-Eaton syndrome is 3,4-DAP. The next is Guillain-Barré syndrome or Guillain-Barré syndrome. It predominantly involves motor system, and it is type of ascending polyradiculopathy. It is most common cause of acute flaccid paralysis. The most important point is there is no bladder involvement in GB syndrome, and the criteria used is Brighton's criteria. This is given in new edition of Harrison. Previously Ashbury criteria was used. Then CSF study shows cytoalbuminodissociation, and the confirmatory test is nerve conduction velocity of motor nerve, and in treatment there is no role of corticosteroid. The next is multiple sclerosis. Exercise-induced weakness is characteristic symptom of multiple sclerosis, and weakness is UMN type. The eye sign involves bilateral INO, which is particularly suggestive of MS. And facial weakness may mimic Bell's palsy, but taste sensations are intact. MRI brain, it will show Dawson's fingers. It may be asked as image-based question also. And in new edition of Harrison, MS is of 3 types only. Previously it was having 4 types. The types includes relapsing MS, secondary progressive MS, primary progressive MS. And for treatment, interferon beta is a drug which is only used in MS. So this was the third part on CNS regarding all important points for NEET PG. I have tried to cover all important points which is relevant for NEET PG exam only. I hope you liked the video. Please like, share and subscribe, and comment what next topic you want. Thank you.